This is a young orthokeratology patient who's worn lenses for a little while now, and vision is pretty good, but the lens is leaving an imprint on the cornea, and the topos look a little bit funny, the post-wear topographies. In the right eye, we've got a little bit of a double ring, and it's not very homogeneous in the middle, not very spherical either. And the left eye, it looks kind of unusual too, but this one, the left eye topography, this one is just artifact. This was captured at a distance, working distance too far from the eye. So you can see that the patient's Ks obviously aren't going to be significantly steeper post-treatment compared to pre-treatment. So this was just a topography that was captured too far away. Might just need to get the patient's lids and lashes out of the way a little bit more, and then start right up close to the eye and slowly back off to get a better looking topography. That said, it may look very similar to the right eye, and so I think we can make some changes to get these lenses fitting a little bit better. Patient does have kind of flat Ks, especially in the left eye for the amount of refractive error there is. So this is going to be a difficult patient to mold. The patient's happy with vision, and that's definitely a good starting point for us. So here's a lens for the right eye. What I would recommend is going a little bit bigger with the lens and a little bit smaller with the OZ and IC. Younger patients, especially for myopia control, we can use a very small optic zone that tends to help reduce the amount of progression they get in their myopia over time, and younger patients really don't complain of glare or halos as much either. And so that will also work in our favor in terms of getting this lens to align on the cornea a little bit better. I think right now we're just getting too much of this lens landing on too little of the cornea, and so we're exerting pressure on too small of an area, and that's leaving an imprint. So with this particular patient, we can probably go up to about an 11.7 millimeter lens. Sounds really large, but if you measure the cornea out, HVID looks like it's right around 12, maybe 11.9. And so if we go about 0.2 millimeters smaller than that, we can go all the way to an 11.7. All your other parameters look good. If your existing power and topo demand are getting the job done, then I would leave those as they are. So we'll just kind of make a mental note that we're at a plus 122 power and 568 demand. We do have to reset center thickness. I'm going to change lens diameter. For kids who don't have very specific nighttime vision requirements, I'm reducing the OZ all the way to even 5.6 for those where I'm really concerned that their myopia is progressing faster than we would like. And optically, it still works well. The patient will have a small treatment zone on the post-wear topography, but visually they see just fine, and they don't have any scotopic vision complaints either. 5.6 and 6.2. Okay, we're going to bring down the power. When we reduce the size of the OZ, we don't have to mold quite as much tissue, so we're going to drop this down to pretty much where it was before. Double check the other meridians and make sure it's uniform. Okay, so now we have a lens which is a little bit larger than before. It has a smaller OZ and IC. We've kept the power and the demand about what it was. And so this lens has more cornea to align on. It should distribute pressure a little bit more evenly, leave less of an imprint. Other things that'll work in our favor is we're moving a little bit less tissue, and especially on a flatter cornea, that's going to give us a little bit better optics. And hopefully the vision will be exactly the same with this lens, but you'll have better post-lens wear exam findings behind the slit lamp and with the tomographer. So those are my thoughts on this case. I hope it helps, and thanks for watching.